I don't want to like jeopardize you guys.
Good morning, everyone. We are just waiting a few more minutes for everyone to get settled. If you could just hang tight for just a minute.
Hey, Meg, we're good to get started if you want to kick us off.
Okay, great. Well, good afternoon, everyone. Welcome to the Clinical Learning Collaborative July. My name is Meg. I'll be helping run this event. Before we get started, please note that you will be muted throughout this webinar. If you have any questions or comments, please type them in the chat box. This webinar will be recorded and distributed tomorrow. And at the conclusion of today's event, please be sure to complete the evaluation that will be sent in the follow-up email. And without further ado, I'll pass it on to our Integrated Health Program Coordinator, Lindsay.
Good afternoon, everyone. Thank you so much for joining us. So we have a couple of speakers for us today. We have Dr. Dana Balanchin, our Chief Medical Officer. She will be presenting on the bulk of this presentation. Also joining us will be Melissa Henry Sweet. She has been an APRN for a little over 2 years at Southeast Healthcare in Columbus. She works in primary care with a passion for substance use disorder, women's health, domestic violence, and human trafficking. She loves working with the underserved and helping all of those that need care. Prior to becoming an FNP, she worked as an RN at a level 1 trauma center for 7 years as a floor nurse and sexual assault nurse examiner. So I'll go ahead and get the slides up for you, Dr. Dana.
Okay, great. Welcome, everybody, and thank you so much for taking time out of your busy schedules and days to join us here. So today, just to set the stage, we're going to be talking about behavioral health, but more in particularly substance use disorder and some philosophy of care foundational items for substance use disorder care and care of those patients in our health centers. So as far as my background, I'm a family physician and also addiction medicine boarded. I have been working in FQHC settings for about 25 plus years at this point in primary care, and now for the last 5 to 6 years more specifically in substance use disorder or addiction medicine settings. And this is a passion topic for me. I love talking about this. I love working with substance use disorder patients and trying to help them get the best integrated care they possibly can. So some of what I'm sharing today are things that I have learned across the years of working in the FQHC environment and in a substance use disorder environment, but some of them are also best practice and evidence-based from a research and clinical data perspective. So next slide, please. So what we're going to be talking about today are reviewing harm reduction versus abstinence-only philosophies of care, and what are the differences and why a philosophy of care is important. We'll be talking about then some strategies to help us with our philosophy of care, and in particular to try to be as patient-centered and maybe move along the continuum of harm reduction a bit for ourselves. So there'll be a couple of strategies. One has to do with stigma and language. The next has to do with patient engagement strategies. And the third has to do with getting comfortable around the regulations and requirements for, in particular, Suboxone here in Ohio and with the DEA nationally. So let's take a look first at some incidence and prevalence of substance use disorder. So these are relatively recent graphics that show the drug overdose death rate increase from 2018 to 19 across the US. And you want to be light on this map and not dark. So you can see for us here in Ohio, we continue to be in an increase mode. So things are getting worse, not better for us. Next slide, please. This looks at emergency department visits and non-fatal overdose numbers for the states that shared data. And this in particular is important because it's kind of a more real-time snapshot of what's been happening since COVID. And you can see that visits have continued to be quite high for all drugs for non-fatal overdoses. The next slide is actually just released data from last week that looks at preliminary and provisional drug overdose deaths for 2020. And you may or may not have heard or seen media coverage of this, but there was a 30% increase in overdose deaths in the provisional data for 2020. So again, we are still increasing nationally, and the crisis is deepening and worsening. I wanted to just take a moment to read from a couple of news articles last week. The first one is from Politico on July 14th. There were 93,331 reported deaths from overdoses in 2020. This is up from 70,980 the year before, making it the largest annual increase in the last 50 years, said the CDC on Wednesday. The preliminary numbers, which will be finalized later this year, underscore the current challenge that we are facing in confronting a resurgent drug crisis that's been both fueled and overshadowed by the worst pandemic in a century. Dr. Volkow, who is the long-serving director of the NIDA, said addiction is a neglected disease. Drug overdose deaths climbed each year for nearly 3 decades before they dipped slightly in 2018. At the time, there was cautious optimism that the tide was turning, and now it appears that the 2018 dip was actually an aberration and not real. So Dr. Volkow also, in a separate article, which was in the Washington Post, said that opioids, primarily illegal fentanyl, continue to drive the death toll as it has for many years. Overdose deaths involving opioids reached 69,710 in 2020, which was up from 50,963 in 2019, according to this preliminary data. Deaths from meth and from cocaine also rose. And she said in an interview that fentanyl has so thoroughly infiltrated the illegal drug supply that 70% of cocaine overdose deaths and 50% of meth dose also involve fentanyl. In many cases, users are unaware that their drugs are laced with fentanyl, which can kill them upon new exposure. So in the setting and framing of all the work that we've been doing, I think it's important for us to realize that we still have lots of work to do and a lot of improvement to go to help reach all of the patients within our practices who have a substance use disorder and to get as many of them as possible into treatment. So let's talk about philosophy of care. Next slide, please. So as we begin to talk about our philosophy of care, there are 2 kind of ends of the spectrum, harm reduction on one end and abstinence only on the other. It's super important that we understand that it's a continuum and that we're all at different places on that continuum in our thinking and our practice. And where we are today is probably not where we were yesterday, and it's also not likely to be where we will be tomorrow. It's important to understand where we are on this continuum and where others that we work with are on the continuum. The reason that's important is because this philosophy impacts almost all aspects of our care and programming. It includes impacting how we might handle a urine drug screen that comes back positive, or even how we might talk about it and document it. It impacts how we would handle a patient's attendance and engagement with counseling, and whether they should or shouldn't still continue on their medication if they're on MAT. It also just impacts the way we view a patient's non-adherence in general and what next steps we would take with the patient. It's also important for the team that we're working with to have these discussions periodically about where we all are on the continuum and to reach a consensus on philosophy and approach within our program and within how we're approaching patients. Next slide, please. So fundamentally, if we distill down harm reduction on the left side and abstinence on the right side, harm reduction generally thinks of addiction as a chronic brain and medical disease versus abstinence-only philosophy thinking of it more as a willful and moral choice that the patient is making. Harm reduction would deal with a UDS that has an unexpected result as a sign that the patient is in need of a higher level of care, whereas abstinence only would talk about potentially a dirty UDS result, meaning that the patient isn't serious and possibly needs to be discharged from our program or their medication discontinued. Harm reduction from an adherence and compliance standpoint, when there's non-adherence going on for a patient, harm reduction says what additional support does this patient need, whereas abstinence-only philosophy tends to look at it as the patient is willfully breaking the rules, which again means that the patient needs punished or a consequence. Harm reduction thinks of addiction and treatment as a long-term journey with the patient, and always we want to get every patient possibly that we can to abstinence, but that is a longer-term goal. Versus in the abstinence-only model, the patient and the prescriber tend to define success as an immediate end, and it's immediate abstinence that defines that success. So I think when we're thinking about philosophy of care, it's helpful to think about what does success look like, and that will start to help you define for yourself where you are on this continuum. So when you're working with a substance use disorder patient, what are you thinking about and what are you using to try to define success with the patient? As I've worked with patients, it has been super helpful for me to think about some of the things that we're going to talk further about as new measures of success. So it's not always about what's in their urine and how their urine is or isn't looking. There are some other things we can think about that help us define success. So I'd love for you all to drop into the chat box as we keep going here. Where do you think you are? Or if you're more comfortable, where do you think your program is currently on the continuum? Are you A, all abstinence only based, or are you Z, all harm reduction based, or are you, like most of us, somewhere between A and Z? So if you guys will chat with each other and with us in the chat box as we keep going, I would appreciate getting that feedback. And again, it's not necessarily that all harm reduction is right. It's not necessarily that all abstinence only is right or wrong. It really is understanding where your thinking is and where your program is approaching things from so that you can be consistent with patients. And as studies are showing that harm reduction is effective, helping to incorporate more and more elements of harm reduction thinking and programming so that you can have the greatest impact possible with your patients. Next slide, please. Lindsay, can I ask you to read this case? We're going to look at a case that actually I need to state that this case and some of this content came from my learning in an echo with Neomed. and Dr. Cristina de los Reyes is who needs credit for some of these foundational principles that I'm sharing currently. And they were also presented in the launch of the Wiseman Echo, which is an all-Ohio echo that just started last Thursday, and that there's definitely still room and time for you to participate in if you'd like to get in a learning community to do more discussing. So Lindsay, will you read this case for us that helps us kind of think about, from a medical perspective, how sometimes the things that we do with a substance use disorder patient might actually sound if their disease was medical?
Yeah, absolutely. So DM is a 30-year-old sugar addict. He was arrested yesterday for sugar possession with intent to traffic. He brought donuts to his job, to clarify. He had 4 previous dirty blood tests with a hemoglobin A1C greater than 10. If he has one more dirty blood test, he will be discharged from the clinic because we only treat sugar addicts who can keep their hemoglobin A1C less than 7. He will be sentenced to 90 days of intensive nutrition class and have 4 random blood glucose checks weekly. He also needs to attend 3 Donuts Anonymous meetings per week and get his sheet signed. If he overdoses on sugar again and goes into DKA, he will get charged with sugar possession. After he gets out of the ICU, he will go straight to jail for a 30-day stay. That will teach him never to eat sugar again and to keep his hemoglobin A1C less than 7.
So for those of us who are on the call, thanks Lindsay for reading. For those of us who are on the call with maybe a medical background, like it almost makes you laugh out loud to read that and or listen to that, because that's not how we think and talk about patients with diabetes. But a lot of the language and the concepts are how we have frequently talked about patients with substance use disorders. And this really does identify and define some abstinence-only concepts and tenets that have been at times maybe helpful, and certain patients respond really well to them, but for a lot of patients actually harmful for their treatment and their progress towards recovery. So let's take a look at a kind of opposing case, case number 2, that would actually show more of an ideal of what in a more fully harm reduction model we would want to see happen for a patient. Do you mind reading that one too, Lindsay?
Yeah, no problem. So SUD is a 40-year-old woman with opioid use disorder. She overdosed last night on heroin. She was admitted to the ICU and treated with grace and dignity until she fully recovered. She was not discharged until she met a peer support worker and a counselor and saw psych for depression and PTSD. Her buprenorphine prescription was filled and the prior authorization was done. And the nurse taught her family how to use a naloxone kit in case of another overdose. She had a follow-up appointment with an addiction medicine specialist within 3 days of discharge. A visiting nurse checked in on her daily for 1 week to assess her recovery status, medication compliance, and ensure rides to 12-step meetings and IOP. Her family was kept informed of the ongoing treatment plan and given information on family support groups.
Thanks, Lindsay. I appreciate that. So that is an ideal world, and I have to be honest that it's not the world still, even though it would be the world I would hope to have most patients receive care in. It's certainly not the world that most of them are receiving substance use disorder treatment in. And so I think as we go forward, it's the thinking is, how do we create more of a world that is patient-directed, patient-centered, and meets each patient where they are, with an emphasis on keeping every patient alive that we can by employing some increased harm reduction strategies, while holding out that we want them really to all get great treatment with medication if appropriate for their substance use disorder, and with behavioral health and counseling all integrated into care for them. So let's talk about some strategies that we could think about that may help move us along this continuum. The first consideration and strategy is to think about language. Maybe be more cognizant of some of the language that you're using in your notes, in your thinking, and in your conversations. And this is a great resource that was developed here by Ohio called Words Matter, Language First. And the link in the slide deck should be active so that you can actually go directly to the site. And it gives you some tools and some helpful tips and things that you can use to improve your language and what you're using with substance use disorder patients and in their care. Next slide, please. The second thing is, stigma. We have lots of stigma still in our society about substance use disorder. We have lots of stigma still within ourselves at times and within our health centers. And so Michigan did a lot of work to develop an anti-stigma campaign, and they graciously allowed us to piggyback on that and to share it. And so this is the link to the Ohio-Michigan anti-stigma campaign that we've been promoting for health centers to use. And the goal of the campaign is really to help you have conversations about philosophy of care with your teams. So it is designed to add questions to meetings or to put flyers and posters up that might spark conversation or thinking among your staff. And it's designed for within the walls of your health center. So would encourage you, if you aren't already participating with us in that, to go to the link and you can start anytime. Next slide, please. The second item that has been helpful to me across the years is to think about how do I figure out where the patient is in their engagement level and what is their motivation, and how do we harness some of that to define different levels or metrics of success for the patient. So early on, asking the patient what their goals are and what matters most to them and how important it is for them to quit whatever substance, along with assessing their confidence about that. Those are all some foundational motivational interviewing elements that are easy to do with a patient, but help set kind of patient-directed individual goals that then become a barometer for, is the patient moving towards that goal as a means of success. Sometimes patients are moving towards that goal even when their urine is not showing what you're hoping for and maybe doesn't have Suboxone consistently in it or is still showing other substance use. And for me, the other thing that has been helpful in trying to help patients with success is figuring out why potentially they started using. Some patients tell me they just used recreationally with a friend and then they just got hooked and couldn't stop. Others say it, quote unquote, makes me feel normal. And some say it's to deal with either emotional or physical pain. And so depending on these answers, it can help us add additional things to treating our patients that help them maintain and achieve and maintain sobriety. So patients who say use makes me, quote unquote, feel normal tend to be patients who have an underlying mental health diagnosis that has not been uncovered and is untreated or undertreated. And so adding elements of mental health treatment as part of their overall plan helps those patients. And then ones who say that their use is mainly because of pain, emotionally or physically, adding elements of either trauma counseling and care to their treatment plan, or if it's physical pain, figuring out how to stabilize and best control the physical pain are elements that help you, again, define different types of success than sometimes we think about our success with this patient population. Next slide, please. So the last kind of place that we're going to spend the rest of our time that can help us move along the continuum from abstinence only to including more harm-based philosophies is to get ourselves as comfortable as we can with the rules and requirements that surround us. And so we're going to talk a little bit in particular about opioid use disorder treatment and some of the considerations there. So first, there are state medical board rules for Suboxone prescribing for both physicians, for PAs, and for NPs. And so there's a link here, and we won't go into all of the ins and outs, but next slide, please. The requirements do have some statement of continuing education. They also have a caveat for psychiatrists, addiction psychiatrists, or addictionologists that they can personally provide the counseling or behavioral health treatment for the addiction. For others, for other providers, it's encouraged that the patient has access to behavioral health treatment and counseling, And if there is no access to that or the patient declines that, then there is encouragement in the code about 12-step meeting attendance. So the rest of the rules outline what you would do to assess a patient, what labs you should be getting. Those labs include hepatitis C, HIV, and syphilis testing, along with some other things, physical exam requirements, treatment plan, psychosocial treatment, and 12-step meetings we've talked about. And then there are some guides for Suboxone dosing, as well as urine drug testing and visit frequencies. The regs also talk about avoiding Subutex or buprenorphine-only products because of the increased risk for abuse or diversion of that product, and the importance of all of our patients having Narcan and ready access to Narcan. So to me, even though these are rules, I think that the intent is really to elucidate and identify some best practices that we should all be utilizing as we practice care for opioid use disorder patients. Next slide, please. So it does still require an X waiver at the current time for us to prescribe Suboxone. And this is a link to some DEA office inspection tips. It is actual normal customary practice for the DEA to come around and do periodic inspections of those of us who are prescribing Suboxone. And their expectations really are fairly basic, that we maintain a paper, an appropriate chart, electronic or paper, sorry, and that we have access to behavioral health and can show where that access to behavioral health is, and that we're doing our prescriptions properly, so having the proper demographic and diagnosis information, as well as the use of both of our DEA numbers on the scripts. Next slide, please. So if they show up at our office, they could request a copy or to see our DEA registration showing our X waiver, a patient prescription list of current patients, how our patients have access to behavioral health, a copy of our actual license, and the practice address that the DEA has is actually where this information should be readily available should the DEA come for an audit. And one tip is to keep these items in an envelope at the practice in a secure location and have a staff member or team member know where that is, and then update the items periodically in the envelope. Next slide, please. You can actually run a patient and prescription report using OARS, and this is a slide that tells you how you can run that report. So that it's relatively, you can certainly do it out of your EHR if that's easy for you, but I'm right now just using this method to keep a report that's fairly updated of who all I'm prescribing to. Next slide, please. So for the remainder of my comments, I just wanted to go through additional things that help us hopefully have a comfort with some of the newer and emerging harm reduction strategies. These recommendations are 2020 updates to the ASAM guidelines for opiate use disorder treatment. And so there are several new recommendations as well as revisions that we're going to go through here that I think there's a theme, and the theme really is trying to make sure that the patient has access to the medications that at this point we know help keep them alive. And you'll see as we go that there are some statements to try to help us as prescribers be a bit more comfortable with patients who can't or won't do the counseling component and or have other substance use disorders going on. So as a new recommendation, ASAM has clearly stated there is no longer any recommended time limit for MAT or pharmacological treatment. Everybody is different. They go through treatment at various rates, and positive outcomes actually depend on adequate treatment duration. A lot of times you don't start to see a patient get stable for 6 to 12 months on their medication and to really have the chance to decrease some of the other substance use. And so if you have somebody that's on Suboxone for less than 90 days or in kind of short treatment, there is increasing data to prove that that is not very effective. And so really, the current recommendation is if a patient is stabilized and doing well on their MAT, whatever version it is, they should remain on that MAT indefinitely. Next slide, please. Another new recommendation in 2020 was around comprehensive assessments. Not to say that these are not important for treatment planning and important to care of patients, but to say that not being able to complete an assessment should not delay or preclude a patient getting on Suboxone or other MAT as immediately and quickly as possible. And so it's important for enabling a low threshold treatment initiation in acute care settings or in our programs. So trying to make fewer hoops and barriers to a patient seeing the prescriber and getting started on medication is the goal. Next slide, please. This was a major revision, and that is their statement of the importance of patients having access to all medications, because not, like Vivitrol is not right for everybody, Suboxone is not right for every patient. And so the rationale here is that we should really reach a point in our programs and in our treatment where Sublocade, Vivitrol, Suboxone, kind of all of the versions of MAT are things that we have as tools in our tool belt, and we can make it patient specific based on which one is best for the patient. And that does include methadone as well, which I know is not something that we can really do in our FQHC setting, but certainly having a source to refer patients for access to methadone is important. Next slide. So this has to do with counseling, and again states that a patient's decision to decline counseling or the absence of available counseling depending upon your location and what it looks like in your community, again, should not preclude or delay them from getting on MAT for opioid use disorder. You can use motivational interviewing and enhancement to continue to encourage the patient towards counseling, because we know that is important and we want to get them there. You can also, as we mentioned, even in the Ohio Revised Code, have 12-step meetings, and attendance at 12-step meetings be part of this puzzle and a way to help get some of the behavioral components if necessary for a patient. Next slide, please. This has to do with management of withdrawal, and the important factor here is to avoid precipitated withdrawal. You do not want to start a patient on Suboxone until they are showing objective signs of what I would consider moderate opioid withdrawal. And recent data, 2021 data that's not on this slide, actually ASAM is now advising that you start with a dose of 16 milligrams when they're in moderate withdrawal as opposed to lower doses. There is less likelihood of precipitated withdrawal at that 16 milligram initial dose than some of the microdosing that has been done previously. Next slide, please. This speaks to what dose of Suboxone should we really be shooting for as far as adequate treatment. And 16 milligrams per day is more effective than lower doses, but there's limited evidence that patients need or get benefit from more than 24 milligrams a day. So the therapeutic range and window that we're shooting for is really 16 to 24 milligrams for most patients. Next slide, please. And tapering. So we've already said we wouldn't taper a patient just arbitrarily, but if a patient isn't doing well or there are other reasons that we're going to taper a patient off Suboxone, these new guidelines are suggesting a slow taper over a period of months as opposed to days or weeks to take a patient off of Suboxone. Next slide, please. So benzos and gabapentin and other things that patients can be either legitimately taking or abusing have given us lots of pause for concern because of the concern that there would be a bad interaction and we're putting the patient more at risk for overdose if they're combining those things with their Suboxone. And so in 2020, ASAM said that for methadone and Suboxone patients who are using benzos or other sedative hypnotics, you really have to do a risk-benefit analysis about co-prescribing or prescribing and knowing that they're abusing. And you see the rationale that the combined use of the medications increases the risk of serious side effects. The harm caused by untreated opioid use disorder can outweigh those risks in a lot of patients. Next slide, please. So I wanted to just close with some of the OACHC MAT best practice, which does try to incorporate integration of care, but also harm reduction concepts into care. And this is a guidance document that lives on our website. And my apologies, I forgot to put the web address on the slide. We can send that out to you. And so SBIRT is important for us to help identify our substance use patients. And the recommendation or best practice is to make sure that all adult patients are getting that SBIRT annually at a minimum. And looking at how more of your providers can become data waived or participate in the care of OUD patients in particular. And so thinking about your primary care providers all getting data waived, even if some of them choose not to use that data waiver, the understanding from some of the training can be beneficial just for them to have. And then integrating MAT care into your overall care and thinking of it as much as a chronic disease as diabetes and hypertension is something we would like to promote. Training all staff, not just providers, but all staff about that chronic disease status and nature of OUD and other SUD. And then for opiate use disorder, offering multiple medications as ASAM endorsed, not setting a definite link to treatment, integrating clinical counseling as an important part of treatment, but balancing that with not making it a rate limiting factor so that patients can't have medication if they aren't able or won't do counseling. Looking at hepatitis, HIV, and STD screening opportunities for all of our patients. And for women of reproductive age who do not want pregnancy, we have an opportunity to use another evidence-based practice, which is LARCs for them for birth control. Next slide, please. UDS is probably a whole talk of itself, but using a combination of point of care, which are not always reliable, and lab confirmed drug screens, which are pretty infallible, to make a kind of combination of how you approach urine drug screening and getting to the point that you can in your program and treatment be able to do some of that randomly is the best practice. Having a program coordinator who helps reach out to these patients as well as track how they're doing is also a best practice. And then incorporating case management functions to help with social determinants of health as well as outside referrals or connections to medical and psychiatric care is also something to think about. Establishing some referrals in your community for patients who don't do well and who need that higher level of care to get stabilized. As far as number 14, it's not possible to have a psychiatrist or an addictionologist everywhere, but figuring out where they are in relationship to you and reaching out to try to establish a relationship so that your prescribers can periodically talk to them is also helpful, especially as prescribers are starting to care for opioid use disorder patients. It's helpful for them to have a colleague who's done it for a while that they can bounce questions off of. We do provide curbside consults here at OACHC. I'm always happy to talk to a prescriber who has a particular case question or happy to talk with you as a program as you're wrestling through some of your program questions or concerns. Narcan, we talked about and you saw in the ASAM guidelines. And then the last two things are remembering that for folks who inject drugs, it's important we're making sure they get Hep B and Hep A vaccination and COVID vaccines now. Our SUD patients are at significantly higher risk if they get COVID to have a hospital or serious outcome with COVID. And then PrEP, for those who are going to have ongoing risk and are currently HIV negative, we have an opportunity to get them onto PrEP. So that concludes kind of the points we wanted to make today. And Melissa is joining us, and at this point, I'm going to ask her what comments she would like to make, and then we have a few questions that she and I will talk a little bit back and forth about.
Great presentation. I am Melissa Henry Sweet. I'm a nurse practitioner at Southeast, and I have been working 8-10 months with Dr. Valangian with the BOR program, and I love it. I did some MAT programming with us, but I actually really love the other program because I get to see the patients every single week, and we're tackling a lot of primary care issues as long as their addiction. It's been fantastic.
Thanks, Melissa. And I'll have you skip ahead, Lindsay. The next two slides are just some source documents for you. But the next slide, maybe just to explain a little bit more about the program that Melissa and I are a part of. It's about a year old now at Southeast, and there is a MAT program that has been in existence at Southeast for a number of years. The BOR program is really kind of complementary to that program, and it is designed to be a bridge, exactly what its name says. So a bridge with low barrier access for patients who've just overdosed at the ER, or they're coming out of other treatment programs and don't have good follow-up, or for patients who just have not been able to engage or wanted to engage in other higher levels of care. This is kind of a starting place for some of them. And I've been actually surprised. We probably have had 150-ish patients at this point in this program, and I have been just totally surprised by the number of them who have used opiates for 20 plus years and really never had access or never chosen to do treatment. And so for a lot of them, it is their first time actually trying to get better. And it's been pretty amazing to see. And you really do have to redefine how you define success, because for many of them, just showing up at an appointment becomes the first level of success. And then the second success point is they're consistently taking their Suboxone and viewing it as a medication. And then you'll start to see slowly less opiate use. And then you can finally tackle all the other substances and hopefully get the patient stabilized with medical care and with psychiatric care, and have them in about 12 months at a point that they're really ready to do more of an IOP or higher intensity level treatment program. So that's the framework and the goal. And there's a JAMA article here that was just recently published about, I think that makes a really important point from a harm reduction standpoint and how we define success, because past month office attendance, and this is really coming in and seeing their provider and getting their prescription. This wasn't counseling or anything else. It was coming in and getting their prescription. It did not matter what was in their urine, if there were other substances, or how consistent their Suboxone ratio looked in their urine. The factor that was associated with a 66% reduction in mortality was that they came in for a visit. And so there is something about just the kind of, as Melissa was talking about, seeing the patient regularly and interacting with them and being there for them and being a safe space that is helping keep people alive. We know the Suboxone and or MAT helps keep them alive, but there's another element too. So if you all have comments or questions, I can't really see the chat box, but maybe Lindsay, can you see the chat box? We can certainly address any of the questions that you have, and if not, I have a couple of questions that Melissa and I will talk about.
Yeah, let me stop sharing my screen real quick so I can read some of these. One second, I apologize.
Okay, so it looks like somebody made a comment about the anti-stigma campaign, I'm assuming, saying it was rolled out at the beginning of the pandemic. Absolutely. And so, yes, as a plug, we would encourage everybody to revisit it. I know things have been super hectic and busy for you all. And somebody put the...
Yeah, I think Tiffany shared the best practice document for MAT that we developed at OECHC.
Great. So if you're a participant on here, please drop your questions in for us. I'm not sure if we can or can't unmute you, but we can definitely answer questions through the chat box. So Melissa, first question to you. What has been most surprising to you about substance use disorder or opiate use disorder patients?
The most surprising is the depth of homelessness among some of the patients. By that, I mean, we have patients that have like all of their family is homeless, and you have the grandpa and the uncle, and they all know each other, obviously. And then, but you always hear about that, but until you really see it, you don't understand the depth of like the issue and everything that they're going through. However, that being said, their resilience is awesome because once you can establish a rapport, they trust you, and then they come and talk to you about things. And like I said, I just love tackling things little by little. And once you have that trust, I kind of think that the visits to me are sort of like, some people when they go to lose weight, they just want to like go to Weight Watchers and have a weekly meeting because they want to be accountable. So even if the patient isn't taking the Suboxone as prescribed, they're still coming and they're being accountable to themselves. I love that.
Awesome, thank you. And what would you say has been most challenging so far for you as a provider?
Sometimes the first visit can be challenging in the sense of building rapport. Because of all the stigma associated, you don't know what traumas the patient has gone through, how they have been treated. And a lot of times the patient is on guard because they're used to being treated poorly. And then a few visits usually can go by at the max, and then they start trusting you. And also if people talk and they know each other, then that rapport can come a little easier too.
Yeah, I know for me, one of the most rewarding things is the journey with the patient and seeing them relatively regularly and being able to see from one visit to the next or 1 month to the next some of the subtle changes like, getting a job or finding housing or getting into a sober living environment. Some of those things as you see patients' lives kind of starting to come back, that is super, I think, rewarding. For me. How about for you? What do you find most rewarding?
I agree with you. I have a patient recently who I would say a year and a half ago, I only saw her in crisis every time. And I saw her the other day and she's so happy. She's working, she's starting school, and she is a completely different person. And it's just amazing. So yeah, it's just so rewarding to see the positive outcomes. I can't even describe it.
Yeah, it's also been super fun and rewarding for me. We've had a lot of hepatitis C and actually a surprising amount of HIV. And it's been rewarding for me to challenge myself as a provider to getting comfortable with initiating treatment for both of those things. And the Hep C has been amazing to see how people respond to those antivirals and to watch their viral load go to undetectable and stay undetectable has been super great. And a lot of them are so excited about that because they've been told so many times that they can't get treated until they're sober for X amount of time. And so they had just given up on ever getting it treated. So that's been fun. And the other thing I love is that our patients tell other patients and recruit other folks who are like needing help and bring them in with them. What
I
are
agree.
your
I can
thoughts,
say
Melissa,
that. Oh, sorry. Calling people to tell them their
No,
hepatitis C is, they don't have a virus load is my favorite call to make.
yeah, it's super gratifying because a lot of what we do in primary care, you don't get that instant gratification.
Yeah.
How about from a harm reduction standpoint, like what has been, I guess, the most difficult switch for you, or what I guess advice would you have for other folks thinking about harm reduction?
Well, coming from a very structured MAT program to this program, I'm glad I have a great mentor to ask questions because it is a different thinking. Sometimes I know some MAT programs, if they don't have their Suboxone in their system in X amount of weeks, then they are considered failure. And you just have to, feel comfortable having a great mentor, asking questions, asking what the next thing to do is. It's probably just the biggest challenge in the shift.
Okay, great. Do you have other thoughts or things, Melissa, that you want to talk about?
I do not. I would just encourage everything. My experience has been wonderful, and it's just so gratifying to know, we can treat high blood pressure and things and incorporate their care into one-stop shop. And we even with Hep C, we have a clinical pharmacist that helps, and we're even doing telehealth visits while the patient's at the visit to us on certain days, so we can get everything while they're there. So also, the patient doesn't have to go to so many appointments and have to figure out how to get money to get to the next appointment. It's amazing.
Great. Thanks, Melissa. Thank you for
you.
joining us, and thanks for everything that you're doing. I do not see questions in the chat box. It does look like you can raise your hand and we can unmute you if you'd like to ask it, or drop it in the chat box. We'll just wait a minute here to see if anybody has comments or questions or other discussion. Okay, Lindsay, there was one last slide. I don't know how much of a problem it is to get back to the slide deck. So the last slide is really just a cartoon that I hope will stick in your head. And a lot of times I feel like we're like this, especially with our substance use disorder patients. I think it's a 6 and the other person thinks it's a 9. Just because you're right does not mean I'm wrong. You just haven't seen life from my side. And so when we're working with our patients and with each other, I think it's important that we remember that perspective and our past experiences really do influence our current thinking and philosophy. And so it's okay that we don't always see eye to eye. That's healthy. It's okay sometimes that our patients don't always live up to our definition of success, but maybe we need to reshift our perspective or think about our perspective and how that may be clouding what success we expect out of them. And so I love the 6 or 9 cartoon. Lindsay, I think that's it from us today. Anything else from you? Anything else? Okay, well, thank you, everybody. That concludes our session, and we really appreciate you joining us. Feel free to reach out to Lindsay or Tiffany or myself if you have additional questions or thoughts that you want to talk about offline.
And I can also make sure that we share the OACHC MAT best practice document out in the handout. So Meg, I'll make sure that we get that to you so that way we can get that out to the attendees today.
Thanks, everybody. Is there, oops, sorry, there's one question that just popped up, if anybody's still hanging in there with us. Is there a website to search for different rehab facilities and or places to go for help in different areas of Ohio? And yes, we will try to get that out to you. OMAS has a site that does keep track of some of that. So we'll try to get that link out as well. Thank you so much for that question, Sarah.
If questions come in, just a reminder to please join us for the upcoming behavioral health networking call next week. And if you're interested, you can email Tiffany T. White at oachc.org.